Our next speaker is Dr. Bhagirath B Solanki, Professor of Medicine at BJ Medical College, Ahmedabad. Dr. Solanki sir will speak on GLP 1RA kidney and CV outcomes. Please welcome Dr. Bhagirath sir.
Good morning. Now GLP-1RA is a lot of noise we are listening for last more than 5 years, and we know about its glycemic benefits. Then we came to know about the CVOT benefits and renal benefits. So some of the meta-analysis I am going to present here. The first few slides may be a repetition which you may have already previously seen. So I have divided into the clinical context, cardiovascular outcome, renal outcome, then evidence, cardiorenal outcome, and then how we can apply clinically. Now clinical context, it has a good glycemic efficacy. We know it is going to reduce the A1C in tune of 1 to 1.5%. And it also has improvement in renal outcome, cardiovascular outcome, and it really addresses the current needs of gap in the treatment, where despite achieving the glycemic control, we are not able to reduce the cardiovascular outcomes and the renal outcome. Mechanism, we know it is going to reduce the sugar as well as weight management, CV protection, and endothelial function. What GLP-1RAs till date have been there? The first came was exenatide, which was twice daily injection. Then we have a liraglutide, once daily subcutaneous injection, dulaglutide, once weekly subcutaneous injection. In between, lixisenatide was there as a faster acting GLP-1 analog. Then semaglutide oral, semaglutide subcutaneous, and now the latest is GLP-GIP combo, that is a tirzepatide. Why CV outcome? Because in year 2010 around, the rosiglitazone mishap happened and lot many deaths because of cardiac event happened in the rosiglitazone patient who were on rosiglitazone, and that created withdrawal of all glitazones, and then FDA made it mandatory that once any drug in diabetes is introduced, not only the efficacy, its CV outcome study also should be there. And the primary MACE point and secondary MACE points have been decided. 3 MACE points usually tracked during the clinical trial. Now what landmark clinical trials are there? The liraglutide trial is leader trial is for liraglutide around 13,000 patients. Rewind for dulaglutide came in 2019 around 10,000 patients. Lixisenatide was Elixa where 6,000 patients. Sustain 6 for semaglutide, again it was for MACE reduction. Excel for exenatide, and Pioneer 6 for oral semaglutide. Now what meta-analysis of all these trials suggests that it was participation of 6 clinical trial, more than 60,000 patients, and population characteristic was that more than 2/3 patients have a established CV disease. Baseline HbA1c was not under control, means an acceptable control to not control, means 7.2 to 8.7. Median age elderly, quite more than 60 to 65, and outcome for follow-up was 2 to 5 years, and the standard method of data analysis was used. Now what it shown? It reduced the relative risk around 12 to 14% with hazard ratio of 0.86 to 0.88. So that is an inversely related to that. Heterogeneity was less than 30%, so there was minimal variability among the various groups, and absolute risk reduction was 1 to 2%, and in ASCVD subgroup analysis, the risk reduction was around 19%. So it was higher than even the relative risk. So stroke reduction also has been found out in subgroup analysis, and the cardiovascular and all-cause mortality were also found out. Heart failure outcome were not that robust with the GLP-1, but the SGLT2 scored over the heart failure. But as we know, the in previously DPP-4 also these trials were mandatory, but SGLT2 is supposed to be faring ahead in reducing the heart failure outcomes. Now renal outcome. In composite renal endpoint, if we see in all this 5-6 trial, then the relative risk reduction for renal outcome was around 7 to 21% with a hazard ratio of 0.81 to 84. It excludes the unity robust pooled data and absolute risk reduction again 1 to 2 year over a follow-up period of 3 to 4 year, and mostly the primary trial which showed it were leader and sustain 6, and secondary trial like Excel and Elixa were there, and that favor that renal outcome also are there. How the renal outcome was measured is by albuminuria regression or reduction in progression of UACR, and eGFR reduction or eGFR fall is maintained or probably is slowed down. So what is the primary mechanism? By anti-fibrotic, anti-inflammatory, by some benefit in blood pressure, and also the robust benefit in weight loss. So every mechanism beyond glucose control is operating here. Now if we look to the cardiorenal outcome, now we have seen after looking to the cardiac outcome and renal outcome separately, if we look to full data of cardiorenal outcome, there is an article in American Journal of Preventive Cardiology where cardiovascular and renal outcome of GLP-1 receptor agonist with type 2 diabetes and meta-analysis of randomized placebo-controlled trial. In this trial, it is around 83,000 patients with RCT, mostly GLP-1 RA versus placebo. 13 some trial were there. Primary MACE outcome and secondary MACE outcome were already decided as a standard mode. Demography, if we see, then around 53% were male and 29%, 30% female. ASCVD, with ASCVD around 26% patient, means at least 3/4 were with ASCVD, quite sick patient. Heart failure patient were around 20%, and patient who had a eGFR less than 60, they were around 16%. So the very sick patient of heart failure and renal failure were around 20%, and ASCVD patient were around 75%. Now what has been found? That all cause mortality, there is around 13% reduction, CV mortality 13% reduction, coronary revascularization was found 14% reduction, fatal stroke was found more beneficial around 26%, non-fatal again 13%, and composite renal outcome was around 24%. This has been found in all these pooled clinical trials. Another one is American Journal of Kidney Disease, where kidney and cardiovascular outcome among patients with CKD, because those were ASCVD more, heart failure and CKD, here more were of CKD. In this around 12 RCT, around 18,000 patients, and it was again GLP-1 RA versus placebo, and eGFR was very sick, means more than 30%, more than 40% reduction, and 50% reduction were around 4 clinical trial. 11 trial look into the composite CV outcome, 7 trial look into the all-cause mortality, and if we conclude this, the GLP-1 agonist improved the kidney and cardiovascular outcome and survival in patient with CKD in array of clinical trials. So what were the limitation? Because there was inconsistent kidney outcome definition, because in various trials were done on a different horizons, and of time, and because of that the universal definition was not included, and it was focused on diabetic complication of most of the studies. Now safety profile, we know that GI side effects and pancreatitis, retinopathy, Dr. Ashutosh sir yesterday only mentioned, but two important organs are medullary carcinoma of thyroid in thyroid and pancreatitis. There is likelihood of gallbladder disease and acute kidney injury, very rare complications in typically volume depleted patients, because these patients are already volume depleted. On top of that, you administer a drug which has a serious GI effect that further causes volume depletion and can cause acute kidney injury. So there is a definitive meta-analysis for primary cardiovascular outcomes, stroke reduction, renal protection, mortality impact, and these benefits are independent of glucose centric benefit, and there is improvement in heart failure also. So our strategy is alternative CV risk. If we compare, then you can take it as an add-on to SGLT2, statin, ACE, ARB, aspirin, and of course with the background lifestyle modification will continue in every endeavors. So what are the contemporary guidelines say about the GLP-1 RA? So ADA is first line, KDIGO diabetes, add if SGLT2 is inadequate to control in CKD patient. ESC guideline again is in population of type 2 plus ASCVD, and it is a standard of care. In obesity also it is type 2, and when BMI is more than 27 it is a preferred agent. In renal, if it is eGFR is more than 15 and CKD staging is around 3 or 4, then it will have more benefit. So definitive take home message is there. There is a reduction of heart failure, there is a ASCVD reduction, 3-point MACE reduction, and composite renal benefits all are there. But a word of caution, the patient who are on stage 3 and beyond, they have already uremic symptoms and they have already anorexia, they are already suffering from nutritional problem. In this patient, adding GLP-1 RA, which is going to worsen all this issue, can be detrimental to the nutrition. So this should be individualized for every patient and should be discussed with the patient appropriately. If patient is intolerant to GLP-1 RA in an advanced kidney disease, then I think it becomes a very individual decision rather than a guideline based therapy. Thank you very much. If any question? Yes, sir.
SGLT2 inhibitor, which has all of them has consistent renal benefits and also heart failure benefits. Some of the drugs has failed to show any cardiovascular benefits, if you call exenatide, dexacenatide. But again, if you see the drugs which have shown the ACVD benefits, 3-point MACE benefits, except the liraglutide, which has shown the CV death, the other has mostly shown the stroke benefit. And again, the drugs which has both the oral as well as the injectable form, the sustained 6, mainly the stroke benefit, but sole, no individual point is significant. And if you again count about the SELECT trial, though it should not be included because that is an obesity trial, no individual point is significant. So probably rather than the molecule as a whole, the individual molecule or their some characteristics may have some favorable effects on the ASCVD benefits.
So in current times, we are now considering it is as a class effect. But you rightly said, depends on the molecule which has been used in particular trial in more number of patients and showing the robust benefit will have always an edge to use by the clinician. I fully agree with you.
And sir, second question is that, as you have already pointed out, that many of the GLP-1 agonists can be given up to the end stage renal disease. But considering the,
Frailty.
fragility and also the side effects, because often they are with the nausea, vomiting. But one thing is very important, that sir, probably in case of the end stage renal disease, or say the stage 4 or 5 disease, hardly we can use some of the molecules.
Yes.
So what is your comments? It is individualizations.
Early CKD means in stage 2 and 3A, up to
Yes.
3A. When you go to 3B, patient, if are on conservative treatment, you discuss with the patient, and if they are able to tolerate, afford, and continue it can for a longer time, then it can be used. But beyond that would be a very risky to use, because it is going to add up the issues for the patient more than the benefits.
Yes.
Yes, sir.
GLP molecule in our clinical practice, it is for sure that all GLP-1 molecules are not same. It is true. One is the molecule which are small, another is the larger molecule GLP-1. One way of classifying these GLP-1 into like monster derivative, and another is human derivative. So all these things actually affect the amount of side effect and the effect. The point is, if you look at the GLP molecules like albiglutide, dulaglutide, these are very large molecules. Unfortunately, in case of albiglutide, that has not been marketed. But if you look at the results of the albiglutide, the weight neutral was the thing, means there was hardly any weight loss, and HbA1c reduction was not that much prominent, means only 0.5, 0.8 HbA1c reduction, hardly weight loss. But the primary endpoint was mainly driven by non-fetal MI and this thing. Only molecule. But that molecule is not available. Look at the dulaglutide. Dulaglutide, if you look at the rewind trial data, the molecule is large. It is hardly going to cross the blood-brain barrier. Still, it is having lots of GI side effects, and the outcome is primarily driven by stroke. And there is a data for the primary prevention also, and that was also driven by the stroke. So that is the one thing, means if you want weight loss, if you want MI protection, probably dulaglutide is not a very good drug to use. But look at the liraglutide and semaglutide. In that scenario, if you look at the outcome, it is driven by both. So what I want to say is there is a very beautiful review article there in Lancet, where they have actually given all three wings, and they try to extrapolate the things into the, in terms of weight loss, in terms of pleiotropic benefit, in terms of HbA1c reduction. What they have found is small molecule crossing blood-brain barrier, mainly reducing proteinuria, is the actually future of the GLP-1 molecule. Means semaglutide like small GLP molecule. And nowadays we have the small oral GLP molecules which can mimic the GLP-1. That is not a peptide. So all these things which we are having in this present era is mainly GLP-1 having some unknown pleiotropic benefit that is constant across the all GLP-1 which is available.
Which is beyond the glycemic
control and weight loss. That is one thing. Another important point is look at the SOUL trial data. This is also very important thing. In that also we have some primary prevention cohort also. So first time a oral molecule is there which is having primary prevention data driven by mix of stroke and MI. So it is for sure that this molecule are future of the therapy, but we have to individualize according to the need of the patient. Like dulaglutide may be a favorite for molecule for the neurologist. Albiglutide may be a favorite molecule for the cardiologist, and these molecules may be one of the drug which is very important in terms of cardiac protection as well as this thing. Regarding this CKD latter stage, we are using these molecules, sir, in advanced CKD patient, even with the EGFR cardiorenal protection, because we see CKM patient lot. So we treat lot of complex patient in this. What our experience is, if you start low dose molecule, then the side effect is very, very less. Like we are using liraglutide in 0.1 milligram. If you look at the starting dose, 0.6, but we are starting at 0.1. We stay 0.1 to approximately 15 to 20 days, and then we increase the dose to 0.3. That is another way of getting this molecule acceptance in those particularly nausea predominant and AKI prone stage. So that can be one reason. Another important point is, what is your target? Suppose you want to control blood glucose. This is one molecule which can provide blood glucose without hypoglycemia. Suppose you want to reduce the cardiac risk, because CKD patients are dying because of the cardiovascular disease. So that is one thing. So for cardiac protection and that, it is a very good molecule. But if you want the patient who is uremic toxin, nausea, vomiting, prone for AKI, probably this is not a good thing to start in that particular stage. That Absolutely. Is my experience. It is not. I may not be correct, but this is what we are doing from last 1.5 years.
Because
this is one of the molecules.
Sir have rightly pointed out that if we have a data of comparing GLP-1 versus SGLT, it would be very interesting, because as far as the renal outcome is concerned, SGLT2 is scoring far ahead, but it is not head-to-head comparison. So that is a point, not in a large number.
Yeah.
Oh, thank you.